This is a big issue. This is a huge issue because as I introduced Dr. Wingerchuk, I set the stage saying most of the people in this room, either you or your loved one, was in the ER or in the hospital at some point with people scratching their heads and trying to sort out what to do. And years ago, in the setting of stroke, when we got clot-busting drugs that became available, what happened over the next several months? A huge public health campaign to educate patients and physicians about getting to the hospital quickly, right? So has everyone here seen the Brain Attack public health campaign? These posters up that say, and you'll see public ads that say, know the warning signs, call 911, get to a hospital. We want to come up with our own version of spine attack, try and educate everyone on the signs and symptoms of these issues, because we do believe time is cord. The sooner you intervene with an appropriate therapy, balancing risks, the better the outcome, and we're trying to prove that through trials. That said, the best medicine is prevention, which is going to be our next talk. For a variety of us in the room, either ourselves or our families, we live under the constant threat of another attack. And this is as much a psychological and anxiety-provoking issue as it is a medical issue. And if we could look our patients in the eyes and say, take this medicine and you do not have to worry about future attacks, it would relieve a significant burden from all of us in terms of the concern. So Dr. Burton, who's an assistant professor of neurology at the University of Texas Southwestern and part of our neuroimmunology group, is going to give us a presentation on immunosuppressants and immunomodulation for prevention of attacks in these diseases, so hopefully we won't need the acute therapies that we were talking about. So, Dr. Burton.
Thank you. It's nice to be here with you today. I hope I can provide you with some information and answer any questions you may have. What I'd like to talk to you today about is disease modification, prevention, mainly of progression and relapses and MS and neuromyelitis optica. So we will cover both disorders. I won't spend quite as much time probably on multiple sclerosis. There are a lot of treatments out there, a lot of research, a lot of FDA-approved treatments and treatments coming down the line, whereas neuromyelitis optica, quite a bit different. A lot of what we've based our treatments on is based on case series, anecdotal experiences, personal experience, and so we'll talk a little bit more about that. My objectives for this presentation is that you'll appreciate that MS and neuromyelitis optica are really distinct entities, and that distinction really leads to them needing to be treated very differently with distinct treatments. I'd like you to recognize that there is a rapidly changing landscape of MS treatments. It was 93 when we had our first MS treatment FDA approved in the form of interferon beta 1b. Beta seron, and more recently Tysabri or natalizumab in 2006, and just this past week we've had our first oral agent approved for MS. So there's rapid changes afoot in terms of MS. And then I'd like you to understand that there are certain treatment objectives that we should all have, particularly with NMO, and that there are ways that we can best facilitate that. So as many of you may be aware, MS is a relapsing remitting illness that is due to inflammation, demyelination, loss of axons and neurons within the brain, spinal cord, and optic nerves. And it is a relapsing illness in 90% of patients. 90% of individuals do have a relapsing course. Disability tends to accumulate in the disease with relapses, though this is much more mild or slower in terms of the quantity and severity of the disability compared to the progressive stages. So as people begin to progress, they tend to move out of the relapsing phase of MS and become more progressive. So our goals in treating MS is one of maintaining remission, preventing attacks. And fortunately, the majority of people do have a relapsing form of MS at the time of presentation. So our treatments are best at doing this. Our disease-modifying therapies prevent relapses, they prevent attacks. They mitigate attacks, so those that do occur are much less severe. They prevent new MRI lesions, and certainly atrophy of the brain and MRI lesions do correlate with long-term disability in MS. And they reduce progression mainly from the aforementioned things. So they reduce progression early by preventing attacks. So the treatments are most effective at treating the relapses and preventing that. Unfortunately, at this time, treating the progressive phases of the illness are much more difficult. In fact, there have been no treatments shown to be effective in primary progressive MS. Some of these treatments are effective in the secondary progressive phase of MS, but they are not nearly as effective as they are in the relapsing phase. At present, we have a number of treatment options. They include FDA-approved treatments such as the interferons and glatiramer acetate, Mitoxantrone, natalizumab, and a number of non-FDA-approved treatments for MS. They're approved for other things, most of them for other autoimmune conditions, but they're not specifically approved for MS, so their use is oftentimes off-label, sometimes in combination with FDA-approved treatments, sometimes alone. Oftentimes they're used as an escalation in disease-modifying therapy to try and better control relapses and progression. These treatments include immunomodulators, things that modulate what the immune system does. They don't necessarily suppress the immune system or suppress the bone marrow, and they certainly include things that suppress the immune system, such as Mitoxantrone. In terms of non-FDA approved treatments, things that are very similar would include alemtuzumab, which is an immunosuppressant, cyclophosphamide, which, as we've already heard, is commonly used when we need to escalate treatments for an exacerbation or an attack. Some of these treatments are very effective. Natalizumab is associated with a 70% reduction in attack rates in groups of individuals with relapsed and remitting MS. Others are more modestly effective, such as the interferons and glatiramer acetate. They reduce clinical attacks by roughly 30% in people with relapsing remitting MS, so modestly effective. Where they really differ and have their place is their ultimate safety. We know through long experience that the interferons and glatiramer acetate, Copaxone, are safe. There aren't a lot of problems long-term that we've run across. Whereas natalizumab has been associated with a rough risk of about 1 in 1,000 for a potentially fatal brain infection. And so as we begin looking at these treatments that are more effective, their escalations in treatment and prevention, we start running into some risks that we need to balance with the benefits. Perhaps our most effective treatment, if it ends up coming to FDA approval, is going to end up being alemtuzumab, which in initial phase 2 trials actually showed a 90% reduction in clinical attacks. And again, there are certain risks there that one would have to look at and accept before considering that treatment. So what does the future of treatment for MS and prevention of remission hold? Well, the first one is this fingolimod. This has just been approved this week. This is the first oral agent approved by the FDA for the treatment of relapsing remitting MS. And it is a fairly effective immunosuppressant, which is going to have some safety concerns. Some of the long-term safety issues we don't have sorted out at this point, but it is going to be an option for many individuals. There are a whole host of other treatments in trial for MS. Some of these, like cladribine, we'll hear from in terms of FDA approval by the end of this year. It's been granted accelerated review, and so we may hear by the end of this year whether this oral agent is approved, and it's also an immunosuppressant. Then there are also immunomodulators, so things that don't suppress the immune system but modulate it, and they include things like laquinimod, BG12 or dimethyl fumarate. These things may end up being safer and are appear to be more modestly effective, such as when compared with things such as interferon and glatiramer acetate, and may be appropriate treatments for other individuals. And of course, Campath or alemtuzumab is in clinical trials right now and was also granted fast track status by the FDA this past summer. So there are a number of things on the horizon in terms of treatment and prevention of progression and relapses in MS. So ultimately, in terms of maintaining a remission in MS, we have a number of things we have to do. We have to understand the goals of treatment, and really, as we look at the number of treatments that are available, preventing attacks, preventing new MRIs, and preventing progression, particularly early in the relapsing phase, is something that's very achievable. And so that is going to be our main goal. We know that early treatment is very important. We've shown in multiple clinical trials that those who delayed treatment compared to those who started treatment early never caught up in terms of benefit to the ones who started treatment early. And so as we approach these different medications, we will have to broach the issue and accept certain risks and benefits as we look at these. And certainly medications and treatment regimens are going to have to be tailored to the individuals with their physicians. And for physicians, we're also going to have to know when to ask for assistance, because for the general neurologist, some of these medications may not be things that they're going to be comfortable with managing long term. So with that, I'd like to shift gears and move on to neuromyelitis optica. Neuromyelitis optica, as you may know, is another demyelinating inflammatory disease. It really differs from MS in the sense that it has a very strong predilection for the spinal cord and optic nerves. The attacks, when they do occur, are often very severe, oftentimes more severe than MS. And the recovery from attacks, which is often pretty good in MS, is not very good. In fact, it's pretty much poor in terms of neuromyelitis optica. Pathophysiologically, it also differs from multiple sclerosis. Multiple sclerosis has long been our classic cell-mediated T-cell autoimmune disorder. Neuromyelitis optica, for all the evidence that is available to us, looks like a humorally mediated immune response. It looks like it's related to antibodies and B cells. So the pathophysiology is quite a bit different. And unlike MS, where the majority of the disability accrues with the progressive phase, neuromyelitis optica, it appears that all the disability is accumulated with attacks. There have been a couple of reported cases of secondary progression with neuromyelitis optica, but that is distinctly unusual. A disability tends to accumulate with attacks in this disorder. So in terms of the pathogenesis, there are a number of studies out there that suggest that it's different from MS. Most of these are going to be related to the fact that there's this aquaporin 4 autoantibody, aquaporin 4 being a water channel present on the astrocyte foot process. The astrocyte is a supporting cell within the central nervous system. And most of these studies show that antibodies mediated or directed against this aquaporin 4 channel, there's associated pathologic changes that can correspond with that, including the antibody and complement, which we've already heard about, deposition in those areas. We see loss of aquaporin 4 activity in those areas of deposition, and we see loss of those aquaporin 4 channels in areas of attack, along with loss of the astrocyte foot process. We also see that acute NMO attacks respond very well to plasma exchange. So we've already heard about plasma exchange as a treatment, and indeed it is at our institution our preferred treatment for NMO exacerbations. These attacks tend to respond much better to plasma exchange than they do to steroids, again suggesting that the plasma exchange is pulling off antibodies and complement and other inflammatory mediators, and therefore is resulting in the improvements that we may see. Other evidence comes in the fact that we have a number of immunosuppressants that have a very strong effect on B cells, and so therefore their ability to induce remission in NMO may be further evidence that it's a different immune process than MS. And in terms of pictures, we have over here on your left what we generally think of as happening in terms of MS. T cell activation, antigen presentation here, or proteins that are presented to cause inflammation, T cells being activated, demyelination and axon or nerve injury. We also see B cells activated, and we have clonal expansion of these, and they end up producing antibodies that, while probably not directly related to injury, we see them in terms of oligoclonal bands in the spinal fluid. Neuromyelitis optica, on the other hand, is associated with this antibody to aquaporin 4 due to some triggering of the immune process through B cells, antigen presentation, and clonal expansion of, I think my pointer just died, of B cells over on the left. And so you get this deposition of the antibodies on astrocyte foot processes targeted to aquaporin 4 channels, inflammation, and destruction, leading to neurologic deficits and problems. So in terms of maintenance of remission in NMO, our whole goal in NMO is to prevent attacks and therefore prevent accumulation of disability. One thing that we know is that NMO, unlike MS, does not respond to immunomodulator treatment. So interferons, glatiramer acetate, some of these new immunomodulators that will be coming down the line are unlikely to be effective treatments for this disorder. And this was shown in one multi-center retrospective study. Most of what we have are retrospective or observational studies with NMO, where patients treated with interferon over 12 months, only 25%, all patients treated with interferon had relapses over a period of 12 months on interferon, whereas 19 patients who were immunosuppressed with various regimens had only 25% had relapses, suggesting that over 36 months, suggesting that immunomodulators are not effective treatments. So the typical things that we usually start in MS are not effective treatments in this disorder. So when we look at NMO, we look at the immunosuppressants, and what I'd like to talk with you about are mainly these 4 immunosuppressants here. Azathioprine, with or without prednisone or prednisolone, has been kind of the mainstay for a long time in terms of treatment of NMO. Mitoxantrone has had a recent trial showing benefit, and then bigger observational studies looking at Mycophenolate and Rituximab, and I think these two are going to be the important ones. So let's talk about azathioprine. It's an immunosuppressant. It's titrated up to effect, or dose. So most people start at 1 milligram per kilogram, and that dose is titrated up. It takes a while to take effect, and so most people are either on concomitant prednisone treatment or corticosteroid treatment, or they are started on a tapering dose of corticosteroid treatment while this is taking effect. Importantly, people need to be screened for this thioropurine methyltransferase deficiency, which increases a person's risk for developing bone marrow suppression and increases risk of infection. So we always screen our patients for this. There are a number of other potential side effects associated with azathioprine. In terms of trials and data that we have to support the use of azathioprine, most of its use really centered around this initial trial where 7 patients with newly diagnosed NMO were treated with azathioprine and prednisolone and remained relapse-free over 18 months. This led to more extensive use of the treatment in NMO. And a more recent review published this year in looking at 36 patients treated with multiple different regimens. The patients receiving azathioprine with or without prednisone had fewer relapses and progression compared to those who were receiving combinations or these treatments in alone, interferon, methotrexate, or cyclophosphamide. And this is an interesting graph from that trial. So 48 treatments were used in these 36 patients. And what you can see, not too well with my pointer here, is that this group is the azathioprine group, and these are all others. And what this represents is deviation in their disability score from their initial baseline when they came in. And so what you can see is positive numbers are bad, negative numbers are good. And so what you see is that people who were started on azathioprine and with or without prednisone, they appear to do better over this retrospective review than those who were on other combinations or other treatments. One of the problems with this trial is that many of these patients were new, and what it looked at was, this is when they were started on azathioprine, these 28 patients, and what you can see is that a number of these patients still continue to have multiple relapses despite being on this azathioprine prednisone combination. And it was a relatively short follow-up period. So the data is all retrospective in terms of looking at this azathioprine with or without prednisone. Mitoxantrone likewise is a immunosuppressant that suppresses lymphocyte production, particularly B cells. There are multiple different regimens that have been used, some with induction periods, some without induction. One thing with mitoxantrone is there is a cumulative dose effect in terms of heart toxicity, and so we cannot go over 140 milligrams per meter squared body surface area for an individual's lifetime. The major risks are the cardiomyopathy, heart changes, cardiac function changes, and leukemia with this treatment. Really, there's only been one prospective trial looking at 5 patients over 2 years with this treatment, and 3 of those 5 remain relapse-free. And looking at the data, many of these patients were treated on medications before starting the mitoxantrone. One patient died of apparent unrelated consequences due to a pulmonary embolism. But 2 patients, they had initially started their trial giving 3 consecutive doses of mitoxantrone, and these were the ones that experienced relapse. So the remaining patients got essentially 6 monthly doses or induction of mitoxantrone, and the remaining 3 were the ones who remained relapse-free during the course of this trial. So this leads us to Rituximab. This is a monoclonal antibody directed against a protein on the surface of B cells. B cells are cells that present antigens. They interact with T cells. They go on to become plasma cells, which produce antibodies. So it is an antibody directed against CD20, a protein on this cell, and it essentially depletes all B cells. And this depletion varies significantly in terms of its duration. In our clinical experience, we've seen people who have had depletion of their B cells from 3 to 18 months with a single dose of this medication. So it's a highly variable response, but it's a measurable response because we can measure B cell counts. There exist various regimens for giving this. One common one that we tend to use at our center is 1,000 milligrams 2 weeks apart for a total of 2 doses. Others base it on a body surface area. And you can monitor these B cells, and typically in our experience, we retreat when 2 consecutive months show an increase in the B cell titers or a percentage, or when the B cell percent of lymphocytes reaches 1%, we retreat. There are a number of trials or retrospective reviews looking at Rituximab, and one of the more recent ones with larger numbers is this one by Jacob and colleagues, looking at 25 NMO or seropositive transverse myelitis patients and following them over a median of 19 months after starting on Rituximab, what they were able to show was a significant reduction in relapse rate and improvements in disability. And one important thing to note here is that most of these patients, if not the majority, were on treatments of other sorts before starting Rituximab and having exacerbations or in relapse. And these treatments included Azathioprine, prednisone, Mitoxantrone, and a number of other things, so various combinations. And this is what some of the data that they graphed out for us here. And so what you can see is that at time 0 here is when these patients were started on Rituximab. And the blocks are where they received treatment with Rituximab. So prior to starting treatment, most were having very frequent exacerbations, and the time is in terms of months. And most, if not the majority of these patients, were on some form of other immunosuppression before starting Rituximab. After starting Rituximab, I think what you can appreciate is a significant reduction in attacks, being these diamonds here. One thing to note here is that the regimen was not standardized, so some were doing it weight-based, some were giving Rituximab 1,000 milligrams 2 weeks apart. What also was not standardized was whether they were having B-cell titers checked, whether they were on a scheduled repeat dosing every 6 months, every year. Some were actually on schedules that if they relapsed, they would then get another treatment of Rituximab. And so I think what you may be able to appreciate is that a lot of these relapses that we're showing are just prior to their next treatment and sometimes after. And what we've seen is that it can take up to a month or more with a single dose at least of Rituximab for B cells to be completely depleted. So we do see this attacks before and occasionally immediately following the dose, and I think you can appreciate that in several areas here that is the case. The last drug I'd like to talk about is Mycophenolate. This is a generic medication now. It's an oral medication as opposed to the Rituximab, which is an IV medication. Mycophenolate is a inosine monophosphate dehydrogenase inhibitor, and essentially what it does is it inhibits B and T cell proliferation and may reduce antibody synthesis. And it's very effective and used in a number of autoimmune disorders and in transplant recipients. And it's dosed at 1 to 3 grams divided twice daily. And it has significant myelosuppressive effects on lymphocytes. And so some people actually will choose to follow lymphocyte counts to monitor the drug's effect. There have been a number of retrospective and case studies looking at this. One of the more recent ones is this, looking at 24 patients who, again, had been previously treated with other regimens, azathioprine, interferon, prednisone, mitoxantrone, cyclophosphamide, a number of different things in combinations, and had failed or had relapses or progression on them. And these patients were treated for a median of about 27 months. And what they again showed with this treatment, it was a significant reduction in their rate of relapse compared to pre-treatment, and improvements in disability. And so, again, another chart looking at this, and what we see is time 0 here. Number of relapses before initiating treatment, most on other treatments during this period, and number of treatments, number of exacerbations afterwards. So again, some people continue to have relapses, a number of such. Other people do very well. So a significant response there. So in terms of our NMO treatment recommendations, what is recommended is immunosuppression. Potential regimens really include Rituximab, Cellcept, Azathioprine, Mitoxantrone. We feel, based on our experience with neuromyelitis optica at UT Southwestern and the evidence that is available to us in the literature, that Rituximab and Mycophenolate may be the better choices to initiate therapy on they seem to have a much stronger, more robust effect on prevention of relapses than the others. In addition, there are things that we can follow to help us monitor at least a biological response to some of these medications, such as Rituximab. We can follow B cell counts. And as we go along and B cell counts start to come up, we know and we can redose rather than waiting to see if there will be another relapse or other problems. So in terms of our treatment recommendations, NMO appears to be a B cell mediated process, and it does not respond to immunomodulators. So based on retrospective analysis of patients treated with Mycophenolate and Rituximab, we believe that these two are probably the better choices in terms of treatment of neuromyelitis optica, and we believe that's demonstrated by a reduction in annualized relapse rate. So with Mycophenolate, it went from an annualized relapse rate in those patients retrospectively from 1.3 to 0.09, and with Tysabri from an annualized relapse rate of 1.7 to 0. So number of relapses a year significantly reduced following transition to those treatments. And then, like all things, there will be safety and tolerability issues that need to be addressed. So in conclusion, we need to think of MS and neuromyelitis as two distinct immunologic processes that require distinct, different treatments. MS treatment options are growing, and the treatment options should be tailored to our clinical goals and what should be patients' clinical goal of no relapses, no progression. And likewise, NMO, the goal should be no relapses, no progression, and so our treatments there should be directed to best achieve this as well. Thank you.